Hi, ma'am. Dr. Jinke.
A very good evening to all of you. I, Dr. Ajinkya Rodge, on behalf of Emcure Pharmaceuticals, welcome you all to today's Women's Day special webinar. As is the tradition of Indian culture, we start any good work by offering our prayers and tribute to God. I request my colleague, Mr. Amadi, to share the Saraswati Vandana before we start today's program. Mr. Amadi.
Mine, can you give me the rights? I'm not able to share. Yes.
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada. Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada. Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada. Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada. Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
Thank you, Mr. Amadi. Women's health has always been a top priority for Emcure Pharmaceuticals since the beginning. Today, on the occasion of International Women's Day, Emcure is very thankful to Indore Obstetrics and Gynecological Society to provide us an opportunity to bring you this online webinar and workshop that is in line with the objective and motive of Emcure Pharmaceuticals to relentlessly strive towards betterment of women's health and create an awareness. For this program, we are joined by a distinguished panel of faculty. With this, I would like to take the opportunity to introduce the Master of Ceremony for today's program, Dr. Mona Kothari. She is a consultant obstetrician and gynecologist with keen interest in high-risk pregnancy. She has actively participated and delivered talks in several society activities and awareness programs. She has also conducted PCOS awareness programs for girls in many schools. She has also presented papers in national as well as international conferences and has been the presenter in many CMEs. Welcome, Dr. Mona. Now, I request Dr. Mona Kothari ma'am to take over the proceedings of this program. Over to you, Dr. Mona.
Thank you so much for your kind words. Good evening to all dear, beautiful, respected ladies of today's evening. First of all, Happy Women's Day to all of you. पापा की वो लाडली, माँ की वो जान, दिल नादान कर देती है सबके लिए अपनी जान कुर्बान. है भाइयों की मुस्कान, परिवार की शान, ये है लड़की की पहचान. आप सभी लोगों को सबसे पहले अंतर्राष्ट्रीय महिला दिवस की बहुत बहुत शुभकामनाएं। अभी मैं like the willingness to listen and the patience to understand is the strength to support. So that's the beauty of the lady. Happy Women's Day to all of you. It's my honor to introduce Dr. Ruma Shukla ma'am. She was the past president of Indore OBGY Society. She is a consultant and head of the Department of OBGY Shukla Hospital and Investigation Center, Indore. She's associated with various programs of Save the Girl Child in Indore, and she has conducted Salute to Womenhood program in Indore with Lok Sabha Speaker Srimati Sumitra Mahajan in 2015, conducted adolescent health programs, regular camps for cervical cancer detection, prevention in slum areas, school girls education program. She got many awards in OBGY work, merit scholarship in MBBS, national scholarship in 1976, and publication. She has done several publications in national and international journal. Welcome, Ruma Shukla ma'am, to chair this session. Welcome, ma'am. Ruma Shukla ma'am.
Thank you so much. First of all, I must give you my best wishes for this International Women's Day. संस्कृत में कहा गया है, नारी समाजस्य कुशल वास्तुकारा। नारी ही समाज की कुशल वास्तुकार है। उसने ही समाज के नवनिर्माण में अपनी अहम भूमिका निभाई है। आज हम उसी तरह अपने यहाँ के कुशल वास्तुकार सर्जन डॉक्टर कविता बापट को इनवाइट कर रहे हैं फॉर द इमरजेंसी सर्जरीज, टॉक ऑन इमरजेंसी सर्जरी, एंड डॉक्टर मनीला कौशल, who is bubbly gynecologist of Indore, young, dynamic. She is going to speak on FCM in ferric carboxyl maltose injections in treatment of anemia. Dr. Kavita Bapat.
Thank you so much, Ruma. Please allow me to share my screen. Screen कहाँ चला गया? I don't know. Screen misplaced हो गया क्या? Thank you so much to the Happy Women's Day, first of all. And the best part is, Ruma Shukla is my childhood buddy. I think I able to see my screen.
Yes, yes.
No.
Huh?
Yes.
Able to see the screen.
No, not yet.
No?
Not yet.
Not yet, ma'am.
It is the earlier one which is coming. Not yet.
Oh, I don't know. I just managed to switch off कर दिया probably. So this is the problem. Thank you so much. Then the अब दिख रहा है? I think emergency is
Yes.
Thank you so much. So thank you so much, Ruma, for giving this thing. And I'm so much proud and thank you for having this program. And the program is really important for us. The emergency hysterectomies, which I am going to talk about because I talk on real hysterectomies. And these are definitely the life-saving procedures. First of all, before starting it, Happy Women's Day is the another point, but I just give my maximum share to Dr. Manjushri Bhandari, Dr. Jyoti Tiwari, and Dr. Sunanda Jain. They are one of the few earliest, the friends, or the didis or the guru or anything. They have given me enough chance to do the emergency hysterectomies at their places, and we all saved so many females of the city. So the emergency hysterectomy at Bhandari Hospital, Arpan Hospital, and at Jyoti Hospital, it has a record because we have saved so many females with this. So this is the topic being given to me. And though we have started this thing, the way to get started is to quit talking and begin doing. This is about listening. So it's a very important thing. Now the emergency hysterectomy, I'm just putting myself, though it's a life-saving procedure, which involves the surgical removal of the uterus and usually performed on the uncontrollable maternal hemorrhage when all the conservative managements have failed. So there is a basically history of this hysterectomy. This peripartum hysterectomy was proposed in 1768 by Joseph Cavallini in Animal Experiments. The first documented cesarean hysterectomy was performed by Horatio Strotter in 1869. And in 1876, Udardo Porro performed the first cesarean hysterectomy in which both the mother and baby survived. So its history of almost 100 and you can say 50 years history of the peripartum hysterectomy is very, very important. And why I am talking in the era where we want to save the mothers without losing the uterus is also very, very important. And either the blood, so many more things. But sometimes we have to take few decisions to save the mother by removing the uterus during the peripartum is another important point. 0.004 to 1.5 per 1,000 deliveries, Tillen says. 0.24 to 8.7. 8.7, I find it's too much per 1,000 deliveries in North American Journal, and 30 per 100,000 following the vaginal delivery, and 270 per 100,000 following the cesarean section. So though we find out it's a very, very less in number while doing the peripartum hysterectomy, but when it comes, it saves the life. It saves the life, it saves the mother, and when we save the mother, it's good for the country because she is looking after our kids and very, very important. Now, these are the few risk factors which lead patients to end up into the cesarean hysterectomy. Number one is a previous cesarean section, abnormal placental including previa, multiple gestation, grand multipara, fetal macrosmia, previous PPH, and coagulopathy. Chorioamnitis is another risk factor. They have divided the peripartum hysterectomy into three parts. One is the circumstances. That's an emergency, indicated, elective. Then sometimes it's an extent. We have to be done with the extent. It can be a supracervical, total, or a radical. Then it's a clinical context. It can be a planned cesarean birth, an emergency cesarean birth, or this is another way when we need it for this. So it's a circumstantial, extent-wise, and a clinical. These are the things. Now, emergency hysterectomy, these are the emergency cases. Number one, 26% is uterine hemorrhage. Placental problems, previa, abruptio, accreta, 11%. Uterine rupture, 7%. And postpartum atony is 5%. Extent of a cesarean section incision into the uterine vessels, 3%. Infection, 6%. And chorioamnitis with sepsis. So abnormal presentation, most common indication. Incidence due to increased rate of C-section. Now, there is a triple P procedure. Triple P procedure includes perioperative location of placenta, delivery of the fetus by the incision above the upper border of the placenta. Why I am including this? Because of placenta previa, placenta accreta, placenta percreta, because of increased rate of cesarean section in the previous sections. So in this section, in this pregnancy, there are more and more chances of placenta previa and everything. So chances of cesarean hysterectomy is also more. Number two, pelvic devascularization is another P by inflating the radiologically pre-placed occlusion balloons in both internal iliac arteries. And third is placental non-separation with a myometrial excision and reconstruction of the uterine wall. So this is a triple P procedure which should be performed before anything else. Now, uterine atony, atonic postpartum hemorrhage is a constant bugbear of the obstetricians, and failure of the sequence of all conservative measures. There is a relationship between the blood loss and the duration of time that passes prior to the decision for hysterectomy. Possibility of hysterectomy getting complicated. The more it's a delay, more chances of having a problems. So this is another big problem with the uterine atony. Then uterine atony is incidence reduced due to the liberal use of pharmacological treatment. Nowadays, we can use the 3T, that's a tissue, trauma, and thrombus. Another important point. The decision making and the timing is critical. We cannot take a delayed decision. If the decision is delayed, the normal patient who is doing an uterine atony can end up in a coagulopathy. And if the decision is taken prematurely, I'm telling you, it's very serious point is, if the decision making is a premature, it's not also good for the health of mother. So timing is critical, and hysterectomy should not be performed too early or too late. That's a very important point. A sequence of conservative measures should be attempted before resorting to more radical surgical procedures. Indecisiveness, delay therapy, and results in a fatal hemorrhage. That's another important point. And increased duration of time increase the likelihood of the hysterectomy will be seriously complicated by coagulopathy, severe hypovolemia, tissue hypoxia. Fourth is a hypothermia and acidosis. And fifth, with further compromise in the patient status. So the duration, timing, decision-making is all very, very important. And when emergency is not, it should be taken care of. ACOG recommends that the hysterectomy is performed for uterine atony. There should be a documentation of first attempting other therapies. These are the cases where patient takes you to more and more court, more suing, more lawsuits, more redemption, and more, you can say, and you should be very secured yourself very much, and the indemnity should be very big when we are doing the obstetric practice and end up in doing the cesarean hysterectomy. It's very, very crucial for all the points, but in most of the cases, suspected placenta accreta hysterectomy should be the primary management, especially when the woman does not desire future fertility. I'm not saying this is the only thing that we should do in a placenta accreta. We should try all the procedures, right from uterine stenting to the uterine artery embolization to the radiological therapies to the balloon inserting anywhere. But in a placenta accreta, the right decision, right taking things are very important. So pre-planning, why you say pre-planning? It's an emergency. Then why I am discussing the pre-planning? The proper consent and explain the possibility of high-risk patients, because it's not going to be a simple thing. Adequate blood arrangements, prophylactic antibiotics, arrangement for the general anesthesia, and a multidisciplinary team is always should be ready. It should not be like that I know everything, I am able to do very good, I am a very good surgeon and I am able to do many more things, but I will also need, and everyone will also need, a multidisciplinary team. Obstetricians, you should not say that I am the only obstetrician doing all those things. You should have obstetrician friends. So then the obstetric anesthetist, which is another important point, those persons who are not giving anesthesia to obstetricians, not able to tolerate the tantrums of obstetrician and all the fuss of the obstetricians. So the anesthetist is also very, very important. Urologist, vascular surgeon, and interventional radiologist. And appropriate instrumentation should be available. It should be, it's really a big pre-planning. And there are the supplies for the peripartum hysterectomy, what heavy clamps will need, what are the Kelly clamps will need, right angle clamps are needed, handheld retractor should be there, self-returning retractor should be there, bipolar tissue devices. Now we use it and it's good. Suction cannula, reparative. I'm enumerating all those things, but they are really important. Hemostatic agents, thrombin, gelatin. Sorry for this. Fluid for irrigation, standard cesarean delivery important, and multiple sutures. Patient's preparation, the stirrup, readily available, bladder catheterization, vaginal preparation, abdominal preparation. Pneumatic compression boots is another important point. Laparotomy drapes, and broad spectrum antibiotics. Stabilization by blood products, because we'll need a massive transfusion protocol, uterotonic agents, multiple large bore intravenous lines, arterial lines, warming devices for the patients and blood products, rapid blood infusers, and intubation equipment. So these are the care bundles. These are being given by the FIGO. And me and Manila is doing CG Saraiya CME at AICOG, and we are going to talk about all these care bundles, very, very important. But the care bundles is another important. That's a consultant obstetrician, plan and directly supervising the delivery. Consultant anesthetist, plan and directly supervising anesthetist at delivery. Blood and blood products available. Multidisciplinary involvement of pre-operative planning. Discussion and consent includes possible intervention such as hysterectomy, leaving the placenta in place, cell salvage, interventional radiology, and all. I'm extremely sorry for this. and local availability of the critical care bed. We all know the importance of the bed during the COVID time. And we all know the critical care bed is also important when we deal with a... Just give me a moment. Now take help. To whom we have to take help? Urologist. Placenta pergrata involving the posterior bladder wall. Partial cystectomy may be required. Interventional radiologist for the suspected accreta. Pre-op placement of hypogastric balloons bilaterally decrease the blood loss and avoid the need of embolization. Being a surgeon, there are the surgical pitfalls. We should be able to know the normal pelvic anatomy. It might be distorted. So we should know very, very much about the pelvis and the anatomy. Number two, vascular pedicles are thicker and more edematous. So that's a problem. And it should be doubly clamped to avoid the slippage of ligature. Small pedicles should be secured, not tied when they are correct anatomical plane without torsion and twisting of the pedicle. Another surgical pitfall, the bladder might be adherent to the lower segment, especially previous section, presence of uterine tears or extensions. Uterine angles might increase the risk of ureteric injuries during the placement of suture. So all those things should be kept in mind. Another important, there may be difficulty in identifying the spur cervix, especially if the hysterectomy following the cesarean section done at full dilatation. And I think these are the very, very common things. The tissue might be friable and can pose added difficulties. Another pitfall, great care is necessary to avoid injuries, organs that are adherent to the uterus, bladder, and nexa, abdominal wall. Another is surgeon must be prepared to recognize and repair the injuries of urinary tract. Hematomas of broad ligament and nephrin structure make a visualization difficult, distort an anatomical relation. Careful exposure of the skilled assistants and attention to hemostasis are primary importance. Need of experienced and senior obstetricians with a second opinion with the experienced one, and surgery should not be delayed. Less definitive procedures with the surgeon has little experience should not be attempted. जो नहीं आता है वो नहीं करना है. Now, incision midline vertical phalansteal choice. Vertical midline is preferred in emergency situation if hypogastric artery ligation is anticipated. Enter by the earliest methods. That's the basic thing. Exposure is based obtained by the traction of the uterus along with retractors. Steps are similar to the abdominal hysterectomy with some precautions. Then the transection of the round ligament. See, it's very, very important. Just go through it, hold it and go through the hole and just clamp it. This is a simple way. Then the tubo-ovarian ligaments, which we always do, all know the simple things and we do it. There's another is a securing the skeletonization of the uterines and just clamp it in a very close to the uterus and very close to the segment cut. Again, for the McIntosh, but the difficulty is a clamping the cardinals is tough. If the cervix is fully dilated, we are not able to reach up to the cardinals. So this is another important thing. If the cervix is fully effaced, palpate the upper vagina. By pinching the palpate the cervix, put a finger and palpate it and find it out. Hooking the finger between the cervical rim and the vaginal wall through the caesarean incision. Put 2 fingers into the caesarean incision and put this thing of hooking a finger between the cervical rim. That will give you the location of the cervix. See, we can see and go through it and we can palpate it through the incision, and through that we can come to know up to what level we are going to do the. So total hysterectomy with dilated cervix is the toughest one, and it's not easy to do the thing. Now the wall repair, each of the lateral fornix is secured to the cardinals of the uterosacral ligaments. Achieve hemostasis by lock suture, and some prefer to close vagina using figure of 8 chromic catgut. It's an old method, but it still be very, very important. So on the both the sides, 8 stay with the things and just close it, all those things. Most of the time, if the emergency is there, we have to do the subtotal hysterectomy. And I think most of us have tried and planned and did the subtotal hysterectomy for many patients. But in stable patients, keep pedicles small and ensure they are carefully and doubly ligated. Sorry. And engorged and edematous tissues and excess following delivery can cause vessel tide and large pedicle slip and retract. But if the patient is unstable, I'm telling you that how much perspiration a patient has, what the patient BP is, whatever the BP and pulse of the patient. But I am sure those who have attempted the uterine atony and done the cesarean hysterectomy, more the patient, we are also unstable at that time. So unstable patients, quick clamping, cutting until the bleeding is controlled, pedicles are tied and ensuring the hemostasis, and total hysterectomy is the operation of choice in cases of central placenta previa. आंखों में भी पानी, सब जगह पानी रहता है. Subtotal hysterectomy is again its advantage: less operation time, reduce hospitalization, and reduce risk of bladder ureter. But the disadvantage is a potential risk of malignancy of the cervical stump, need for the regular cytology, and bleeding and discharge associated with the residual cervical stump. These are the problems with the subtotal hysterectomy. Now, post-operative, number one and most important is a documentation. Record an indication of the surgery. Have a discussion with the patient when she recovers, especially the primary parous women. I'm telling you, this is a really the maximum indemnity and maximum suing with this. Bladder drainage 7 to 2 days if the bladder injury. Tackle postnatal symptom with required counseling. So post-operative is also important. Complications, again, we can talk about the morbidity, transfusion, coagulopathy, ICU requirements, mechanical urologic injuries, and reoperation. 2 to 4% intra-abdominal hemorrhage and other organ damage. And people need another thing. Incidental bladder injury, gush of clear fluid in the operating field, repair at primary surgery preferred, lowers the risk of post-op vesicovaginal fistula. Confirmation of ureteral patency, bladder closure by 2 or 3 layers, and continuous bladder for the post-operative. Oophorectomy sometimes due to inadvertent clamping of the ovarian ligament, at times to stop bleeding from infundopelvic vessels. Sometimes we have to. And 5% peripetual hysterectomy is one adnexa was removed to stop bleeding, means they were just adherent, rotating, turning it. Sometimes we have to remove. The oophorectomy is being done when again then you are answerable to everything to the patients. These are the changing trends. Increase in cesarean section, accreta, hemorrhage has deteriorated due to increased success. So many things, iatrogenic agents, PG's embolization, catheters, surgical procedures, these are coming up. Reduction in elective procedures. So it's another, and there is a downward trend into the incidence of uterine rupture in the modern obstetrics and reduces. So these are the trends. And even cesarean hysterectomy is less and less nowadays, as it has to be done, is used to be done previously, because there were not so many radiological interventions, so many previously diagnosed. So the placenta previa used to be as a surprise. I'm not telling you nowadays, but in 15, 20, 25 years, not the correct sonography or something. So this is an hysterectomy. Now the summary is a dilemma where decision regarding emergency hysterectomy is at last resort to save the life of the mother. Should not be the first chance to do all those things, and can be made rarer by good antenatal care, active management of the labor, early recognition of the complication, and performance of the C-section at the time, as well as will not need much more blood products if the hemoglobin of the patient, by giving the IV Orofer FCM type of things during the antenatal, good antenatal care, we can save many more things. The triple P procedure is another important thing to save the cesarean hysterectomy not needed. And the last is sequence of conservative measures to control uterine hemorrhage should be attempted before swiftly instituted. Fifth point is indecisiveness and a delay in therapy result in a possible fetal excessive hemorrhage. Fetal excessive hemorrhage. Another point is should be seriously complicated by coagulopathy, hypovolemia, tissue hypoxia, thermia, acidosis, and further compromised status of the patient. And timing is critical to an optimal outcome. Hysterectomy should not be performed too early or too late. So take home is emergency obstetric hysterectomy is necessary. Evil in obstetrics. I'm telling you, it's an evil. It should not be a fun thing. It curtails the future childbearing of the potential of the women, which is really bad, and saves the life of mother. That's also very, very important, but it's an evil in obstetrics. And another point is morbidity is attributable to its indication and underlying disorders rather than the procedure itself. An important point again, the postgraduate training is this rare skill to prove life saving. किसी ने सीजरियन हिस्टेक्टोमी जिंदगी में देखी नहीं होती है बिना PG training, and they do it and they have to do it sometimes. So PG training, some models, some things to be told, and a rising rate of cesarean section, multiple pregnancy are bound to increase the incidence of emergency hysterectomy in the future, but we should save ourselves for many things. So thank you so much for the patient listening, and I'm so thankful to Indore OB-GYN Society, my own society, and especially the President, Secretary and Treasurer, Manila, Jyoti and Shweta, being given the chance to speak me today. And thanks MCure for giving me the chance of the subject which is very close to my heart, and hysterectomy ke upar raat din kabhi bhi bola ja sakta hai. That's my problem. So thank you so much once again. And those who have joined to listen to me, I'm really thankful to them. That's their outcome. Thank you so much.
Ma'am, more than 200 people have logged in live. Wow. And we have on YouTube more than 50 people who are watching it on YouTube.
So much. Thank you so much.
Dr. Mona ma'am,
Now, this is a very precise talk, Madam Kavita ma'am, very excellent about the emergency hysterectomies. And now I go forward to the Dr. Marila Devi for talking about the FCM.
Okay, please allow me to share my slide. Am I audible and visible?
Yes, ma'am, both.
Okay. So a very good evening to all. And this is a special day today. So happy Women's Day to all of you. And it is just not today. We have to celebrate this womanhood every day. And that's what OB-GYN specialty is doing it day in, day out. So at the outset, I would congratulate Dr. Kavita Madam for presenting her talk so well. And we know that she's a hysterectomy queen. And she spoke so well about hysterectomy that, there was, this is actually a need of our, and as ma'am truly said, that this skill should be learned by every postgraduate trainee, and there's a need of our. So thank you, ma'am. Your throat was bad, but still you completed it very well. We are really thankful to you. Thank you, MCure, for doing this program for this special day. And I'm thankful to my team, Dr. Jyoti Banglowala, Dr. Shweta, who are doing hard work to organize this program. So let me come to the topic, the ferric carboxymaltose in the management of iron deficiency anemia.
Ma'am, you can make it full screen.
Yes, I'm trying to. Okay. So when we talk about anemia, sometimes we really feel that such a boring topic, why to talk about this again and again. So it's not like that, because even when I'm going through the statistics recently, it was to my surprise, and I think that you would also feel it that way, that anemia prevalence is increasing in India. And this is not, this is a study from National Family Health Survey 5, which was done in 2019 to 21, wherein they found that from the previous years, the prevalence of anemia was increasing in all set of population, right from the women, men, non-pregnant, even in children. So again, this topic becomes very important in spite of a lot of initiatives done by FOXY, Government of India, a lot of NGOs working on it. And I think every doctor, being it a pediatrician, gynecologist, cardiologist, everyone is day in, day out are educating all population to prevent anemia. Still, the prevalence is increasing in our country. So we have to really work on it. We have to understand where we are going wrong. So the first and the foremost, we need to understand whenever the hemoglobin of anyone who comes to you, like pregnant women, non-pregnant women. So I would be focusing my talk on women only, since it is a Women's Day. And also our set of population are females. So whenever anyone comes to us whose hemoglobin is lesser than 11 or 12, then we first need to go for first need to evaluate the cause of anemia. So it is not like that all anemia are iron deficiency anemia. There could be other nutritional deficiency like folic acid, vitamin B12, copper, and so on. And there could be many other causes as well, like thalassemia, sickle cell G6PD deficiency. It could be anemia due to malignancy, chronic infection like tuberculosis, malaria, chronic renal diseases, chronic UTI, and lot many. So the first and the foremost workup that is important is to know the cause of anemia and then to embark on the treatment. So this is what we always teach our postgraduate, that just the hemoglobin check is not the guarantee that it is an iron deficiency anemia, but we should always remember that it is the most common type of anemia, especially in our set of population. And especially when I talk about pregnant women, this is very common. So we have to understand that why we are talking about pregnant women in general, because during pregnancy, the iron requirement increases when the mother is carrying a single fetus, the requirement is 1000 to 1200 milligram. And this iron requirement increases as the trimester of the pregnancy goes on. So in the initial part, it is 0.8 milligram per day, and that increases to 7.5 milligram per day in the third trimester. And when we are talking about an Indian population, our diet, diet which normal Indian female is taking, the maximum absorption is never more than 4.5 milligram per day. So we can very well understand that with the diet, with just the diet, you're not going to fulfill or prevent the iron deficiency anemia, because our set of people are not there is lack of availability, accessibility, and affordability to the diversified food. So there is a difference between Western world and Indian world, because here we are not taking a lot of fortified food, and our the type of intake we are taking is very much different. So all the pregnant women are supposed to take some iron preparation to prevent iron deficiency anemia. That is very well said, and WHO endorsed this statement. And we as a gynecologist all understand that if the mother is suffering from anemia, there are a lot of antepartum complication as well as fetal problems. So the risk is to the mother as well as to the growing baby. So if we want to prevent maternal morbidity and perinatal morbidity, we have to work on the prevention and the treatment of maternal anemia. And it is very essential to prevent, to improve the overall health of women in the country. So again, a very basic slide, how to diagnose an anemia. I need not to remember all the difficult this data. I just always remember 2, 12, and 11. So any cutoff less than 11, I would take it seriously in a pregnant woman. And if she's not pregnant, less than 12. We should not look into whether it is mild, moderate, or severe. Any type of anemia needs treatment, because if it is there, it is going to cause a lot of problem to the women. So just remember 11, 7, and just add 1 to it for non-pregnant women. So when we come to the diagnosis of iron deficiency anemia, as I said, we need to find out first the cause for anemia. And if we think that everything else is normal, then we have to look into the red cells indices. And out of them, MCV is the one which is very important. And these days, RDW, it has come up with a very important, this is very important test nowadays. And in all the complete blood count, you will find this parameter. And if you think that the lady is having low MCV and an elevated RDW, then it is an iron deficiency anemia, and one need to start with iron therapy. So if you want to differentiate it with thalassemia, you have to look into this RDW, and this is decreased, wherein an iron deficiency anemia, it is increased. Now, if you're going for a serum iron test and a total iron binding capacity test, it is not of that importance, so don't go for it. The most important test here would be serum ferritin. So serum ferritin level less than 30 microgram per deciliter is taken as a cutoff to treat iron deficiency. And we also do this test for prognostication in the pregnancy. That is, if you have started with iron therapy in someone and she's not getting the response, or you are having doubt regarding the type of anemia, that on peripheral blood film you're seeing it is a microcytic anemia, and you're not able to make it out that it could be because of chronic inflammation or sideroblastic anemia, then you have to do a serum ferritin to make a differential diagnosis, especially when the patient is non-anemic and at risk of iron depletion. Sometimes also when the patient is having thalassemia, like carrier thalassemia minor or sickle cell trait, and her hemoglobin is going down during pregnancy, so we are not sure what is causing that fall. We have this thing in mind, it is nutritional deficiency, it is iron deficiency. So it is always good to do a serum ferritin before starting the iron, and then do it for prognosis. Like once you have done it, if it is low, then only you start iron. And once the treatment is over, you can further do it to prevent iron overload in such patients. So now come the most important part of this talk, for which this whole thing was plotted. It is the role of parenteral iron therapy. So we all know that we give oral iron to our patient, and most of the time they are not taking it, whether they tell you or not. But I always used to ask my patient the color of the stool, and most of the time they say it's okay. So I understand that they are not taking iron. So what to do about all this? Because with starting with the iron, they are having gastritis or some other problems, and they stop it suddenly. And as we discussed before, that iron is must to prevent iron deficiency anemia. So what to do for this? So I believe all the practitioners agree to me that IV iron therapy is superior to oral iron in terms of speed and absolute extent of rise in hemoglobin, and also replenishment of iron stores. So it is a quick answer to the compliance thing and the speed with which the recovery is required. So the only contraindication where one should not give this parenteral iron is when the pregnancy is less than 12 weeks. There is a lack of facility for resuscitation, because sometimes there could be an anaphylactic reaction, and one should not take this IV iron outside the this hospital setup. So it is very important. And also when there is a risk of iron overload, don't give parenteral iron. So when we talk about parenteral iron, the 4 molecules that comes into our mind is iron dextran, all in textbook now because we are not using it. Iron sucrose. We have been using this molecule for long, but the problems with that particular molecule was that you have to give multiple doses. You have to call your patient again and again and again. Every time when she comes, you are going to prick her veins. Then there are 2 more molecules into market. One is ferric carboxymaltose and iron isomaltoside. So it is said that iron isomaltoside is more liable iron than ferric carboxymaltose, and there's low clinical evidence, especially in Indian set of population. Although this is also into market, but we are more frequently using ferric carboxymaltose. It is not just that the MCure people are doing this program in particular, but it is that if you think about yourself, you might have used this molecule sometimes, and we are using it more commonly. So further, I'll take my talk on this particular molecule, that is ferric carboxymaltose, which contains high amount of iron in single dose. And with all our studies, which I'm going to present now, we will find out that the hypersensitivity reaction is lesser. So why and how to choose an ideal parenteral iron? Because an ideal one should have few properties, like the molecular weight should be high, the stability of the molecule should be good, the half-life should be long, it should be isotonic with low antigenicity, and the injection, the most important is that the time of injection should be short, and you can give maximum doses in a single shot. So what is ideal is this, and when I compare with the 4 forms of iron, the most common, which comes near to ideal, is ferric carboxymaltose. So, as I had already specified the good qualities of this molecule, the one thing I want to put it here, that we need not to do a test dose for this FCM, because what we used to practice is that we started slowly, but I have never seen such, and also it is not me in particular, but most of us and the study says that the test dose is not required, and the infusion time is also very small. So how would we decide that who need and how much is required? So this FCM has got 2 preparation. One is 1000 milligram and one is 500 milligram. So 1K is for 1000 and 500 milligram is the usual dose. So how we do calculate the dose, because supposedly a woman is having mild anemia and her weight is less than 70 kg, which is quite usual in our population. So she would need 1000 plus 500 if the HB is less than 10. And so more or less you would require either 1000, 1500 or 2000 milligrams. So you have to just see the hemoglobin level and the weight of the women and calculate the doses. And it is very easy. Supposingly you are using 500 milligram, just take 100 milligram of normal saline and 100 milligram of normal saline, dissolve it into the 100 ml, that 500 milligram, and infuse it over 6 minutes. And if you're using 1K, that is 1000 milligram, you have to infuse it over 15 minutes. And here you have to dissolve it into 250 ml of normal saline. So I find this thing very good, that the infusion time is very small. It is just that the patient walk into OPD, get the injection done, no test dose, and in a single shot, you're getting the whole dose which is required. So that makes it cost effective and more compliant. So initially, I remember that there were many initiatives by the government, and it was also brought into by NHRM and various other government policies, that why not to give in parenteral iron at the time of tetanus vaccination. It is done for the prevention because of the non-compliance and the cost. But I think if we actually compare the cost of the whole iron therapy in the 8 months and so the women is taking, the price comes to same. But since when it has to be taken by government, they look into so many factors. But I remember there was good initiative taken where along with the tetanus, this shot, parenteral iron was given, and lot many women, and in that particular set of population where this thing was done, the incidence and the prevalence of the anemia was found very low. So now let's see the clinical evidence. That is what was the basics from the theory, and now see what is the clinical evidence. Now I remember when this molecule was introduced into market, it was just for the use in postnatal period. Initially, there were global studies, and then many pregnant women were taken and given this FCM. And this global studies have found that it was very safe to be given during pregnancy, and the hemoglobin rise was found as high as 3.6 gram per deciliter. So we were quite relieved with these studies coming up. And now we have endless studies in our Indian population, wherein the patients of anemia were given this molecule, and the average hemoglobin, you can see here that it ranged from 2.6, or the lowest was 2.1, and the highest was 5.5. So what else you want from a single shot where the rise is as good as this much? So now we have enough evidence from our own population, and it is found to be very safe, clinically effective, and having no side effect during antepartum period. There's no risk to the fetus, the growing fetus, and there were also long-term studies done where the neonates were also followed. till a long time to know the effect and the side effect of this FCM when given to the mother, and the effect on the growing fetus and the neonatal outcome. So when we talk about the safety, the side effects are the first thing which comes into mind, and the most common side effects were rash and itching. So this is very common, which could happen, but it is not life threatening. And if it happens and the patient is in hospital setup, you can always give an injection of Dexona or something to get it relieved of. And the most important thing that as of when we give blood transfusion, we check with the oxygen saturation and vitals and all that, which is not required in such case. So that really makes it very safe and effective to use. And in a normal hospital setting, you can give this. So this is what I was talking about, that no adverse effect in terms of perinatal and neonatal outcome were observed in newborn of women who received FCM during pregnancy. So with all these studies, we were pretty bold now in giving it during pregnancy. Now, these are again the similar studies we talked about. And yes, there is always a confusion that should we go with oral iron or should we go with an IV iron sucrose? So you have to actually decide it according to the compliance of the patient. There's no harm even giving it as a first level of treatment to all of your pregnant women. It is just that it is invasive. You have to prick on her veins, and if the patient is ready, then of course you can go for it. So this is the initiative anemia mission, wherein the management protocol was given. So this was an initiative through the government of India, and wherein they said that you can give either iron or IV iron sucrose or FCM as a first level of treatment, and further also if the patient is refractory, you can challenge her. So this was all about the use of FCM in pregnancy. Now, the very good thing which I feel is very important, that once the lady has delivered, there's blood loss, PPH might have happened, mild PPH, or sometimes, you're dicey giving blood products because the patient is stopped bleeding, she is vitally stable, there's no hemodynamic instability in her. So we are just, halfway that should we go for blood thing or not. So the best option here is that patient is already in hospital having an IV access. So giving her a shot of IV parenteral iron. So parenteral iron in postpartum period is the best thing you can offer to your patient, because whatever may be the blood loss, average blood loss after a normal delivery, if you think is 500, or a cesarean section is 750 cc, or if it is patient ended up having more bleeding, then what's the harm in giving her a shot of parenteral iron? And we know that her hemoglobin has fallen by 1 gram, and this particular thing is going to increase her hemoglobin level by 2 to 3 gram%. So I think I would highly recommend it in the postpartum period. Now, the third part where there is a management, when the management of gynecological condition is required. So at times, a patient walks in at your clinic and she was suffering from adenomyosis, menorrhagia, intermenstrual bleeding. And we know that she needs surgery for ovarian tumors, sometimes laparoscopic hysterectomy, but the patient is just unfit because of her hemoglobin fall. And at most of the time, if she's having fibroids or adenomyosis or something like that, it is the iron deficiency anemia, which has occurred due to excessive blood loss. So the best answer to these gynecological conditions who are unfit for surgery or during the perioperative period is to treat them with this ferric carboxy maltose. The best idea is to admit, that doesn't need even admission. You can give it in your OPD setting, in a daycare setting. in spite of what we usually used to do, it is 6 grams, 7 gram, you need 3 blood transfusion and then only we can operate. So here what you can do is just infuse for just 15 minutes the FCM 1500 milligram, and then you see the rise, and within a week more than 2 to 3 grams. So the patient has got a benefit of not getting this blood transfusion, which is very, very important, because it should be a drive. Say no to blood whenever we can do this, because blood is it is a natural resource. We cannot make it, we cannot produce it. It will come through the human resource. So anything that can replace the need of blood should be promoted. So in all the perioperative patient in gynecological condition and puberty menorrhagia, right from that menorrhagia due to gynecological pathologies, you can use this parenteral iron. So it is so it is safe and effective alternative to blood transfusion for correcting iron deficiency anemia in a shorter duration prior to gynecological surgery. So I think I had covered the use in pregnancy, antenatal period, postnatal period, in gynecological condition, before any operative surgeries, and so here I'm going to conclude my whole thing, that obviously it is superior to oral iron when we need to correct the anemia speedily, and we want to increase the hemoglobin percentage because we have less time left with us at the time of delivery or to operate. And obviously it is also going to replenish the iron stores. Of course, it does not require test dose and no hypersensitivity. You can give it in a very short duration, and there is a substantial global as well as Indian evidence which is not available with any other molecule. So obviously we are more confident while we give it to our patient. And yes, if you're worried about the neonate, then of course it is safe to give, and the safe for the newborn as well. So that's all about my talk, and I'm very much thankful for your patient listening. So thank you, everyone.
Very elaborative and informative talk by Dr. Manila. It's very on the very most common complication or most common problem of the Indian female on the anemia, and is like very it's a very common problem is the anemia, and very thanks to Emcure for introducing such a wonderful molecule FCM for treating the anemic female, and thanks to Dr. Manila. It's a very informative talk.
Thank you, Mona, for the nice summarization. And that's a very special day today. Anemia prevention in women, which should be taken as a key project. And it was a project for long for FOGSI. And still, I believe that we have to go a long way to treat and prevent anemia in our population. So I'm really thankful to everyone who have joined us today. Kavita Madam, it's an excellent talk from your side. Mona, you have done excellent and wonderful comparing. So do we have any questions to discuss? Dr. Ajinikya?
Yes, ma'am. If we have received a few questions from the participants. If Mr. Avijit, have you forwarded the questions here? All the questions are here?
You forwarded, no?
Yeah, just one query is there, that what is the, is there any outcome related to neonatal impact on FCM usage?
No, it's all good.
I would request all the faculty members to give their expert clinical opinions regarding the questions.
This question has come from Dr. Gauri Rai, MP. That what will the neonatal is there any neonatal outcome, any study there on FCM?
So I had put it on my slides. There were many studies which was done on Indian population. As I said, I may be right in a way, but initially when this molecule was introduced, this was the first question which came in everyone's mind, that whether it would be safe for the newborn or not. Everyone who was asking the same question. But now we are pretty confident about this thing, because it's being used over so many years and there are clinical evidence. So we cannot go with our own experience. It is the clinical evidence which we follow always. And it is truly in favor of using it. It is safe. Dr. Gauri, it is quite safe to use it, and it is safe for the newborn as well.
I think the supporting evidences are that there will be I think there should be studies. Are they regarding the weight of the baby given the FCM and the Apgar score at the time of birth? Are they? Do we have this type of studies? And are you able to support that? Do we have?
Yes, ma'am. We do have such kind of studies. In fact, Dr. Sanjay.
Because only on the few parameters we can say they are good for the babies if the iron thing. But from our knowledge, as with the Manila stock and everything, if the hemoglobin is good, the outcome is good. What do you say?
Yes, ma'am.
All of us.
True.
So the hemoglobin is good. It means the baby is good. So we are increasing the hemoglobin. At the end result will be good. So I think it's not. This point has to be substantially and evidence based, that they need it in that manner. I think the fetal outcome is good.
Okay, ma'am.
Yes, most of the time we are giving this molecule in the second trimester, after the second trimester of pregnancy. So the neonatal outcome, there is no problem in neonatal outcome. We are not giving this particular molecule in the first trimester of pregnancy. So there is no chances of any malformation or other things.
Yeah, absolutely, absolutely.
Ma'am, Dr. Vijaya Jyoti from Telangana, Hyderabad has asked that should we keep doctor under monitoring for 15 minutes or 10 minutes at least, because she does it.
For while giving the injection?
After giving the injection, she monitors the patient for 10 minutes. So
it is always advisable to monitor the patient.
I think without observation, the injection is not being given. No, am I right?
Yes.
No.
Yes, you're right.
Observation is important. We cannot leave patient, It's our responsibility once the injection, the drip has been started. So it's under observation. 100% observation is needed.
This message should clearly go that IV or parenteral iron should not be given at home setting. It has to be given in the hospital setting.
Institution.
Yeah. So you just don't need a doctor. You just need a monitoring that if something bad happens, we are able to handle it. So
at the end of the day, doctor is responsible. So yes, it's under the observation of doctor.
Okay, ma'am, there is a comment from Dr. Kiran Chavda that improved hematocrit is visible only after 15 days of giving parenteral iron, as I have seen in my case.
I think, Manila, have you talked about the reticulocyte count in this case?
Madam, actually, when you are giving FCM and you want to see the results, it is always advisable to wait for a few weeks. I mean, what book says that parenteral iron, the best outcome will come 3 weeks after giving the injection. But yes, the studies which we are taking into consideration, they have said, they have enumerated that they have checked with the hematocrit after a week or 10 days, and it was found
so 2 weeks
increase.
2 weeks time.
It is the required time.
It's the crucial time, but the hemoglobin rise will be seen after 3 weeks.
Yes.
But the reticulocyte count in 2 weeks. So it's an indication if the reticulocyte count is improved in 2 weeks, then we are done.
Okay, that's it, ma'am. There is no other question related.
Thank you so much. मेरे को दूसरी meeting में जाना है. So thank you so much.
Thank you so much,
Same thanks to the Indore OB/GYN Society for having this meeting today on such a crucial day. Thanks our chairperson, Dr. Ruma Shukla, and our sweet moderator of today.
Thank you so much.
Thank you
very much, everybody, and happy Women's Day once again. Thank you from the bottom of heart. Kavita, thanks a lot.
Thank you so much.
Accepting and always accepting the programs.
Thank you very much.
Thank you, everyone.
Thank you so much.
Thank you.
Thank you so much.
Shweta ma'am, thank you all.
Thank you, Amardeep. Thank you. Bye. Bye.
Mona ma'am, thank you.
May I know how many participants were there?
238 participants were there.
Wow.
From across India.
Great.
Despite of having all the programs, we have 238. It means something because
Yeah,
program